Alaikum warahmatullahi wabarakatuh. Bismillahirrahmanirrahim. Here MBBS. Today we will discuss viral keratitis, especially herpes simplex keratitis and herpes zoster ophthalmicus with special reference to the eye involvement. Learning objectives of this lecture are that at the end of the lecture you must know symptoms, clinical features, of the herpes simplex keratitis and herpes zoster ophthalmicus, and you must know how to diagnose and treat herpes simplex and herpes zoster ophthalmicus. Viral keratitis. Herpetic eye disease is the major cause of unilateral corneal scarring worldwide, but in developed countries it is the most common infectious cause of corneal blindness. Etiology of the herpes simplex keratitis is the herpes simplex virus. It is a double-stranded DNA virus. It has two types, herpes simplex virus 1 and herpes simplex virus 2. The herpes simplex virus 1 causes infection above the waist, infection of the face, lips, and eyes, and herpes simplex virus 2 causes infection below the waist, that is called genital herpes, but it may be transmitted to eyes venereally or at birth, causing the conjunctivitis and keratitis. Primary infection of herpes simplex keratitis means there is no previous exposure of the viral infection. It spreads through the droplet infection, though the direct inoculation is very, very rare. And the primary infection is uncommon during the first 6 months of life due to the immunity conferred by the mother to the neonate. It affects the children of 6 months to 5 years of age. Primary herpes simplex keratitis causes ocular rash. The skin vesicles involve lid and periorbital area, and it may cause unilateral follicular conjunctivitis. Preauricular lymphadenopathy may be present. And we treat this primary herpes with acyclovir ointment if required, otherwise it is self-limiting. In this picture, you can see the herpetic vesicles on the lids and periorbital region. Now we come to the recurrent herpes simplex keratitis. It usually affects the young adults. So after primary infection causing the primary herpes, the virus travels up into the trigeminal ganglion and stays there as a dormant. But subsequently, when favorable conditions are present, it travels down and affects and causes the keratitis. And it may be due to decreased immunity, and in immunocompromised patients, whenever the patient have long-standing illness, ultraviolet radiation, hormonal changes, trauma, and trigeminal injury. As far as recurrence rate is concerned, it is 10% at 1 year, 23% at 2 years, and 50% at 10 years. So in case of herpes simplex keratitis, when the cornea is involved, causing epithelial keratitis, the patient presents with mild discomfort, watering, and blurring of the vision. And when you examine the patient, you may find initially opaque epithelial cells and overlying epithelium is intact, but later on, central desquamation causes linear branching dendritic ulcer, and this dendritic ulcer is located centrally. And this dendritic ulcer have peculiar features. Ends of the ulcer have characteristic terminal buds, and the virus-laden cells at the margin are present, and they are stained more with the rose bengal, and the bed of the ulcer is stained more with the fluorescein. So the other signs of the herpes simplex keratitis are the corneal sensation is reduced. So conversion of dendritic ulcer to geographical ulcer, ultimately if it is not treated in time, amoeboid configuration, and ultimately it may heal with persistent score and may cause the corneal vascularization. So whenever you come across a herpes simplex keratitis, you must keep in mind the herpes zoster keratitis, healing corneal abrasions, acanthamoeba keratitis, and toxic keratopathies in topical medications. They all causes the dendritic keratitis, but in this case, the dendrites are not as peculiar as herpes simplex keratitis having terminal bursts. In these cases, they are tapering and linear. So diagnosis of the herpes simplex keratitis depends upon typical dendritic lesions of the cornea. But for academic purpose, you may culture the with the tissue culture. It is a costly affair, and polymerase chain reaction can be done to diagnose the case, but it is not usually needed. In this case, in this picture, you can appreciate early epithelial keratitis, only the opaque epithelium of the cornea. In this picture, picture A, you can appreciate the early dendritic appearance. In the picture B, the late dendritic, and in C, the further enlarged dendritic keratitis, which is stained with the rose bengal, and the periphery of the lesion is, these are the dead and dying cells stained more with rose bengal, and central desquamation is stained with the fluorescein. In the picture D, you can appreciate the geographical or map-like stage of the dendritic ulcer. This map is just depicting the northern areas of Pakistan. Here you can appreciate the dendritic keratitis stained with the rose bengal, and so what is the treatment of the herpes simplex keratitis? In this case, we institute purine or pyrimidine analogs to form abnormal viral DNA. So the replication of the virus is halted. We use acyclovir 3% or ganciclovir 0.15% ointment. Acyclovir 3% ointment can be used 5 times a day. Topical trifluridine 1% drops may be used, as effective as acyclovir. And we also gave topical antibiotics to curb the superadded infections. If ulcer refuses to heal, you may debride the ulcer and then use the acyclovir ointment. And prophylactic systemic therapy with acyclovir may be given, and it is said that in case of prophylactic systemic therapy, the recurrence is less. So that is all about herpes simplex keratitis. Now we will briefly discuss the disciform keratitis. In disciform keratitis, the patient presents with gradual painless blurred vision and halos around light. And when you examine the patient, you may find central zone of epithelial edema, stromal thickening, keratic precipitates, pores and descemet's membrane, Wessely ring, mild anterior uveitis, and intraocular pressure may be raised. In this picture, you can appreciate a case of corneal edema and keratic precipitates in case a patient of disciform keratitis. The central disc-shaped area is edematous, having keratic precipitates on the posteriorly on the endothelium. In this picture, you can appreciate folds and descemet membrane in patient of disciform keratitis. So what will be the signs when you examine the patient of disciform keratitis? You may find stromal thickening, keratic precipitates, descemet membrane folds, Wessely ring, and reduced corneal sensation. You can appreciate Wessely ring that is present in disciform keratitis. It is an immune ring of stromal haze around the main lesion. It is viral antigen and host antibody complex. This faint ring haze may stay even after complete recovery. So what is the treatment of disciform keratitis? In disciform keratitis, we use topical steroids with antiviral cover, and we tapered this in next 4 to 6 weeks. If we stop the topical steroids early, recurrence is very common. So we use the topical steroids under cover of antiviral for 4 to 6 weeks. Then we use prednisolone 0.5% once a daily a few weeks. But later on, fluorometholone, a weak steroids of 0.1% may be used alternate days to curb the recurrence. So that is all about stromal disciform keratitis. Now we will briefly discuss the stromal necrotic keratitis. In this case, epithelium is intact and the viral may invade into the deeper tissues, that is the substantia propria, causing the tissue necrosis. On examination of the patient, you may find cheesy and necrotic stroma of the cornea, profound interstitial opacification, and ultimately, when the healing occurs, it is with scarring and vascularization. And sometimes, if the lesion continue and necrosis continue, it may cause the perforation of the cornea. In this picture, you can appreciate the cheesy necrotic substantia propria causing total haze of the cornea. Here you can appreciate vascularized corneal lesion ultimately healed with opacity and vascularization in case of stromal necrotic keratitis. So how can you tackle the stromal necrotic keratitis? Use the topical antiviral agents and cautious use of steroids under antiviral cover to curb the inflammation, and the antibiotic cover is must as to curtail the superadded bacterial infections. That is all about herpes simplex keratitis and its complications. Now we will discuss herpes zoster ophthalmicus. It is caused by a varicella zoster virus. Varicella causes chickenpox, varicella, and shingles in herpes zoster ophthalmicus. Varicella zoster virus and herpes simplex virus belongs to same family, morphologically identical but different antigenically. So it is a double stranded DNA virus. When it initially attacks the patient, it causes chickenpox. Then the virus travels up in a retrograde manner and stays dormant in sensory root ganglion. That is the trigeminal ganglia, semilunar ganglia of the trigeminal nerve. So in herpes zoster ophthalmicus, ophthalmic division of trigeminal nerves is involved in 50% of cases, and involvement of the external nasal nerve. Whenever there is involvement of external nasal nerve, that is called Hutchinson's sign. Lesions on the side of the nose and tip of the nose are present. It means external nasal nerve is involved, which is a branch of nasociliary nerve. So there are more chances of involvement of eye having ocular complications. So what is the mechanism of ocular involvement? It may be a direct viral invasion causing epithelial keratitis and conjunctivitis, or it may cause secondary inflammation causing occlusive vasculitis, leading to episcleritis, scleritis, keratitis, and uveitis. So whenever there is a reactivation of the virus, it causes necrosis and inflammation in the sensory ganglia, so that it damages the nerves and causes anesthesia of the cornea. Ultimately, it may lead to the neurotrophic keratitis. So what is the risk of ocular involvement? So ophthalmic division of the trigeminal nerve is involved in 15% of cases, and whenever there is a Hutchinson sign, that is the involvement of external nasal nerve, a branch of nasociliary nerve, more chances in that very patient is that it will involve the cornea and other ocular complications. As far as age of the patient is concerned, it is the disease of elderly in 6 to 7 decades. Whenever you find shingles in children or young adults, you always look for immunodeficiency or malignancy or any other cause which affects the immunity of the patient. And the patients with AIDS have more severe disease. There are 3 phases of herpes zoster ophthalmicus: acute phase, chronic phase, and relapsing phase. And what is the initial phase is the acute systemic disease, in which there are systemic features, and that is the prodromal phase. It precedes the rash. There may be fever, malaise, headache, and the symptoms may vary from itching, burning sensation to very severe boring or lancing pain. That is the pre-herpetic neuralgia. Then, of course, the vesicles appear and the patient present in the eye department. When you examine the patient, you may find the distribution of the lesion and skin rash in the distribution of the ophthalmic nerve. Painful erythema with maculopapular rash, and then vesicles appear in the distribution of the ophthalmic nerve. Ultimately, they become confluent, forming pustular phase of vesicles. Then crust formation is there. There may be large, deep hemorrhagic lesions. So the healing may occur with residual skin destruction and depigmented scars ultimately. In this picture, upper picture, picture A, the involvement of left side of ophthalmic nerve, you can see the lesions on the side and tip of the nose, that is the Hutchinson sign. In the lower figure, picture B, also involvement on right side, vesicles and edema of the lids and periorbital region is there. And of course, involvement of the tip of the side of the nose is also there. In case of herpes zoster ophthalmicus, only a peculiar or respective dermatome is involved. If right ophthalmic nerve is involved, the lesions are only on the right side. Vesicles will be only on the right side. Of course, edema of the skin and subepithelial tissue may overlap on other side, otherwise lesions will not be present on other side. In this picture, you can appreciate picture A, the vesicle formation, in the picture B, confluent crusting, and the picture C, hemorrhagic rash with the involvement of both the ophthalmic and maxillary nerve, and ultimately healing has occurred with residual scarring, and you can appreciate this in picture D. In this picture, you can also appear a rash in Herpes Zoster Ophthalmicus, ultimately crust formation, healing crusty lesions. So what is the treatment of acute systemic disease? You always treat with oral acyclovir or antiviral systemically. In case of herpes simplex keratitis, you may not use the systemic acyclovir, but here the systemic use of acyclovir or antiviral is must. We give 800 milligram 5 times daily. Intravenous acyclovir 5 to 10 milligram per kg in divided doses is needed in case and where the encephalitis is present. We can use other oral antiviral agents, valacyclovir and famciclovir. We can use the systemic steroids to reduce the inflammation, or when there is involvement of the systemic complications like encephalitis, to reduce the inflammation. Symptomatic treatment of skin lesions is needed. We use topical steroids with antibiotic cream. So what is the acute eye disease? Whenever there is involvement of the eye, there are certain lesions, but when there is involvement of only the skin and no involvement of the eye there, even then it is called Herpes Zoster Ophthalmicus, because the ophthalmic nerves are involved. But when eye is involved, it may cause keratitis, initially acute epithelial keratitis, usually after 2 days of rash. You may find fine dendritic or striate lesions. These dendritic are different from the herpes simplex keratitis or dendritic lesions. They have bulbous ends, but in this case, the lesions are tapering one and the ends are tapering one. Then comes the nummular keratitis after 10 days of rash. In this case, multiple fine granular subepithelial deposits are there. So halo of stromal haze is there, causing the decreased vision. After 3 weeks of rash, there may be disciform keratitis may be present involving the central portion. So initially the nummular keratitis. So if it is not treated in time, it may convert into a chronic phase. In this picture, you can appreciate the nummular keratitis, the subepithelial involvement of superficial substantia propria, causing the subepithelial haze. So, in the herpes zoster ophthalmicus acute phase, there other ocular complications are conjunctivitis, episcleritis, scleritis, and interior uveitis may be present. And neurological complications may be there, involvement of cranial nerves, third, fourth, and sixth, optic neuritis, encephalitis, and sometimes contralateral hemiplegia may be there. So what is the treatment of acute eye disease? We use oral acyclovir 800 milligram 5 times daily, topical acyclovir 3% ointment 4 times daily, topical steroids along with antibiotic cover, cyclopelagic drops, and non-steroidal anti-inflammatory topical drugs can be used. In chronic phase of herpes zoster ophthalmicus, the keratitis may be present, nummular keratitis, which may persist for months. You may find disciform keratitis, ultimately causing scarring and vascularization, neurotrophic keratitis, when there is a anesthesia of the cornea due to involvement of the trigeminal nerve ganglion necrosis, and you may find mucous plaque keratitis. In this picture, you find the mucous plaque keratitis along with conjunctivitis. The lesions are stained with the rose bengal. Now come to the herpes zoster ophthalmicus chronic phase. In chronic phase, you may come across with other ocular complications like ptosis, mucus secreting conjunctivitis, scleritis, and post-herpetic neuralgia. Mind you, this post-herpetic neuralgia is very, very severe, very agonizing for the patient. Patient sometimes goes into depression, may have suicidal tendencies, and it is very, very difficult to treat. So what is the treatment of chronic phase? Use the topical antivirals, topical steroids combined with acetylcysteine to curb the mucus formation and tackle the post-herpetic neuralgia. And you may denervate, chemical denervation or the surgical denervation of the nerve is needed. Now come to the herpes zoster ophthalmicus relapsing phase. It may occur or linger after even 10 years. It may be due to sudden withdrawal or reduction of steroids. And most common lesions in the relapsing phase are episcleritis, scleritis, iritis, glaucoma, nummular, disciform, and mucous plaque keratitis may be present. So this is all about herpes zoster ophthalmicus. Ladies and gentlemen, thank you very much for patient listening. Now I am giving you the assignment. In this, you must write down difference between herpes simplex keratitis and herpes zoster ophthalmicus in terms of symptoms, clinical features, and treatment. And your response, you can respond on given WhatsApp number and email address, and your attendance will be according to your response. Thank you very much, ladies and gentlemen, for patient listening.